Good morning, everybody. I'm Dr. Vaderhobli. Um, the highlight of this topic, of this presentation, is for all of you to know a special technique that's worked really well at UCSF, both in my practice and also in the AGD clinic. I joined UCSF in 2007. My interviews were more harder than Dean Reddy's because mine took 1 year long. And the final question that Dean Featherstone asked me was, where do you want to join UCSF? I told him I want to ride my motorcycle all year long. And at that time, Dean Featherstone also used to be a big motorcycle fanatic. So he said, hop on over. We need to form a motorcycle group, and the rest was all history. But here I am since 2007, talking about composites, talking about digital dentistry, CAD/CAM preps, and everything. I've also run the HD program since 2010. I have 26 residents, all from Southern California, all the way up to Eureka. Um, Over a period of time, because of my expertise in dental materials, they call me the bondodontist, right? So it's a specialty of general dentistry. And occasionally I do get a lot of requests to train film actors back home in India, and I do that here and there. One of my main goals is to turn pro in the next 3 or 4 years. So you'll probably see me shrink or bulk up, right? So just bear with me. Right? So conflict of interest, no financial interest in any dental companies. I don't get paid to give lectures, especially today. Also a principal investigator in all the research grants in the artificial intelligence that's founded by one of our former students, Ali Sadat. A patient walks into your practice, he has a missing tooth, or his tooth is going to be extracted, anterior tooth. You have a lot of different options, right? You have the time-tested RPD. That's usually patients hit that single tooth replacement because always flips and flops. You have the fixed partial denture, either ceramic or you have a PFM bridge. You also have the single wing metal Maryland bridge implant. That's the gold standard, if you will. Do nothing, but also there's a special technique known as fiber reinforced composite bridges, right? So apparently, when I started my career here at UCSF, we used to do this a lot in the pre-doc clinic, back in the HD clinic also, and the students usually loved this technique a lot. But over the course of years, we actually this technique is somewhat forgotten. I'm trying to revitalize this technique. Okay, so what are they, right? So fiber reinforced composite bridges, as the name suggests, it's a composite that has fibers in them. Usually you have composites, you have polymer, you have monomer. The monomer component has zirconia fillers, glass fillers, silica fillers. But instead of having fillers, now you have fibers, right? The fibers can be carbon fibers, Kevlar fibers, or it could be your polyethylene fibers, right? So you have the fiber reinforced composite that can be fabricated by the lab indirect technique, or if you're a good general dentist, you can always do a direct technique. And this is what my presentation is all about, how to be a good composite dentist, right? So it was introduced in 1960s. Again, if you look at all the literature back in 2000, they didn't have any good clinical success rate because people did not want to invest too much time doing clinical trials in these. But then later on, when composites started becoming more and more um, better for in the hands of general dentists, that's when you have lots of evidence-based protocols that come up, and then you can actually go through all the papers. And you get a much better protocol in terms of bonding composite to the tooth structure. Right? So the fibers, you have glass fibers, aesthetically pleasing, very easy to use, but the problem is very poor strength. Then you have carbon fibers. Disadvantage is very expensive. It's always unaesthetic. Kevlar fibers, bulletproof, difficult to cut the fibers, so you cannot manipulate the composite. You have Vectran fibers, and then my favorite has always been the ultra high molecular weight polyethylene fibers. Okay, these are the same fibers that are used for bulletproof vests. So in order for you to cut these fibers when you're actually placing in the patient's mouth, you need special scissors, right? You just cannot use your burr, or you cannot use your regular scissors to cut these fibers. Um, the matrix, right? So now the fibers are embedded in pre-polymerized monomers, right? But the monomers are bis-GMA. Now, once when you start listening to my lectures in your D3 years, you'll know the exact composition of composites, how you can manipulate composites to get good clinical outcomes. But for now, for the ease of this clinical scenario, we're going to use this polyethylene terephthalate glycol (PETG). That's your resin material, in that resin material, you have all these braided fibers that give extra strength. These same fibers are used for a bulletproof vest. So in order for you to actually manipulate these fibers in the patient's mouth, you need to know the principles of bonding. You need to know the principles of different generations of bonding agents using in dentistry. Okay. So as a general dentist or as a dentist, you'll have an opportunity to be a superhero in trying to save tooth. Right? Many of times, patients walk into practice, broken down tooth, and what do? You try to save it, right? So you put these glass fiber posts. These are nothing but your polyethylene fibers that are stretched, polymerized, and made into special cones. And these are actually glass fiber posts that you have the opportunity to use in your pre-doc clinic curriculum. Then occasionally, Dr. Lin calls me and asks me to splint weakened teeth, and I do that, periodontal splinting. And the most common use for the fiber reinforcement is always chair side tooth replacement, single tooth chair side tooth replacements, direct technique. Of course, for orthodontic retainers and space maintainers, I have not had much success with that. So I'm going to focus more on the chair side tooth replacement and splinting therapy. Right. So the fabrication, you can always call up the lab and ask them to fabricate an indirect composite bridge for you, right? That's much more cost-effective option for the patients. Or if you have all the time in the world, I'm sure you will, once when you enter clinics, you have 3 hours for a POE or 3 hours for a hygiene, so you might as well spend 3 hours to actually do a good composite dentistry, right? So I'm going to show two clinical pictures, or maybe four, depending on the time. But I'll go over the step-by-step clinical scenario, clinical protocols that I've actually had greater success with. Okay. So the first clinical case, right? So this was back in 2008 when Dr. Peter Loomer, he was a periodontist. He calls me up and said, Dr. V, I need your help. I have this patient, staff's close relative. He has this tooth that needs to be extracted, and we need a good option right away because he has some important interviews coming up over the next couple of hours. And of course, right, it's always lack of planning on patient's part does not constitute an emergency on my part, right? So that's the thing I always tell students, like, depending on how the patient is, if the patient is very, very nice to you, now, that's always that the physical attribute always look into mental attribute, right? If the patient is actually very yelling and screaming, I have no intention of taking care of him at that particular time. But this patient, since it was requested by the periodontist, I said, okay, right, let me just take care of this patient. So what do, right? The first and foremost thing, get all the fibers, everything ready. You have either ribbon fibers or this polyethylene glycol fibers. Again, you have a lot of different companies, a lot of different manufacturers that make these fibers. Okay, back in 2007, we had only two fibers, two companies, but now Ivoclar, 3M, Kerr, all the companies make these fibers because it's a huge market that's coming up. Probably in the next 5 years or so, when you go to all the CDA or ADA meetings, you'll probably see more vendors trying to sell these products, and this is where most of the materials will be invested in, at least at UCSF. Um, the first and foremost thing you have to do is, since the tooth will be extracted and you got to replace that tooth with composite, you got to measure the actual mesiodistal dimension of the tooth, right? So you take a dental floss, you measure the mesiodistal width, now from the cingulum area to the other cingulum area. So and then you take that measurement, you place it right next to the fiber because that's the exact length you need to cut the fiber, right? Then there's all the lingual aspect. Okay, I'm showing you the lingual aspect. Usually when I do a hands-on course, we do this Typhoon model, and the pictures are from the Typhoon model. So you etch the lingual aspect, regular phosphoric acid etch, 20-second etch, rinse dry. Then I use my 7th-generation bonding agents. If you don't know the generations, I request you to please go back and read your textbook on the generation of bonding agents. Scotch Bond is the bonding agent I love to use, and this is what I'm using right now. You light cure it. You put a tiny amount of flowable composite. You tuck one end of the fiber on the flowable composite. You extend the fiber on the next part of the tooth. You stabilize the fiber with the flowable composite, and you light cure it. Right. That is your fiber placement on the tooth. So then you slowly add your composite. You bulk the composite up. And if you look at the facial view, actually, I've put a nice convexity to the fibers because this is going to be an area where composite's going to stick onto the tooth, because now I have a template and I'm building the tooth with the fibers incorporated. Since it's a fresh piece of composite, the bonding is always predictable. If it's more than 24 hours, there is no way this composite will bond to this particular fiber, right? So since you're doing everything right away, it's more easy for you to control. And then I build the tooth up, place the wedge if you want to get all the embrasure area perfect. But having said that, so this is a case, the same similar patient. Dr. Loomer did the extraction, he did the socket preservation. I believe he used a hydrogel, and I like using Teflon tape. My favorite to go tape in order for me to get the contacts, in order for me to get a nice cervical contour. So the fibers are actually placed on the lingual aspect, right? Very thin fibers backed with composite. This entire tooth is built with my three types of composite. I have my incisal translucent composite, then I have my shade A3 composites in the cervical, and then A2 in the middle, right? So you build this composite up, and patient now actually he has some sort of a resemblance of a tooth compared to what you saw before, right? The previous picture before he was hopeless, right? But then he goes on for his interview, he comes back, a week later, you actually add more composite. And this is where you love enjoying dentistry, because now you have a perfect opportunity for you to be an aesthetic dentist, right? So you add composite, you make it look really pretty, make it look like a tooth. And this is what I did, right? In different shades of composite. Unfortunately, at the pre-doc clinic, we have just a couple of shades of composite, but then the main goal, again, as I said, going forward is to get all the opacers, all the tins, everything in it, so that you can play around with your anterior composite dentistry, right? So this is what it was. So finally, right? Everything, tooth number 8 was built everything with composite, right? I've followed this patient up until 2017, and I still had it in his mouth. The original plan was for him to get an implant, but then he just didn't want any implants, and that's why I hate doing this, because the periodontist hates me, right? Because they want to do something else, but then I end up doing something else, right? But this is what it is. So so this is a technique actually I know I used to teach the students, if it plays. Yeah. So this is the putty matrix technique. Again, I've skipped all the initial way of fabricating this putty matrix. But then if you're building a tooth up, right? So using this putty matrix, you take impression right before you extract the tooth, and then you put this putty matrix again as a template, and you slowly add a composite, right? So all you're doing is using your one end of the plastic instrument, you're contouring the composite, you're making sure you're vibrating the composite with your plastic instrument. This is one of the best technique you can ever do when you're adding composite. Is always vibrate your instruments, right? If you do this vibration technique, all you're doing is you're self-lubricating the instruments to such an extent that the composite sticks to the tooth. It doesn't drag onto the instrument. You'll probably see that, right? When you're doing clinical composites, the minute your composite doesn't stick to the tooth, but instead it gets dragged onto your instrument, that tells you you've contaminated the bonding site. You have to re-etch and do all the rebonding, everything together. But for now, this technique, probably once when you go back to your sim lab, you can try this vibrating the composite technique. Again, you can always play around with the colors, always play around with different translucency of composite, but the incisal and the lingual is always translucent composite. You absolutely cannot go wrong with a translucent composite, right? You do that as a scaffold, and then on top of that, you can use your A3 or AF2 composite. Right? Again, you don't have to go fancy with all the perlfrost or other composites that manufacturers sell you, but keep it very simple. That 2 to 3 shades of composite, vibrate your composite with your hand instruments, and you're gonna get a much better outcome in terms of your actual uh, uh, composite buildup. And this is the same technique that I use in actually building up most of my composites, especially in the anterior tooth. This fiber reinforce always works in the anterior tooth. Single tooth, always more predictable, right? Then there's another case that we did, clinical case 2, patient walks into our AGD practice, a broken down a lateral incisor. And these are the cases that are much more easier for us to get a great outcome, right? So what do you do this? Here you extract the tooth right away. I'm going to skip all this, extract the tooth. Here I'm measuring the dental floss with the floss because I know the actual length of the fibers. Extract the tooth. Again, I'm going to skip all the extraction part. You can always do a socket preservation if you need to. I'm sure Dean Reddy can actually um, um, tell me this too. One of the most hardest part in doing any anterior restoration is trying to maintain the interdental papilla. I'm sure over Zoom we have all the prosthodontists logged into this meeting, and if you ask them, after Dr. Setia or Dr. Acharya, they'll probably agree to this, right, Dr. Dean Reddy? Sorry, right? Yeah. So this particular technique, what we do is we extract the tooth, we cut the kernel, the root portion off, right? Because the tooth is already broken, and you try to refix the tooth with the fiber as a template. And this is what I did, because the hardest part is always trying to maintain the interdental papilla. So with the extracted tooth, I'm maintaining the interdental papilla so that later on it'll be much more easier for the restorative dentist to get a good predictable outcome with the restoration. And again, anytime you use any product, right, always go through the manufacturer's instruction, because this will save you a lot of headache. You know, when the D3s, D4s go to a community clinic, the bonding agents are completely different. They don't even use this. We use the Elite. We use the Ferrari of bonding agents, Scotch Bond in the student clinic floor. But outside, they have different systems. I always tell students, right, when they text me, I ask them, just read the instructions, right? So if they read the instructions, you will actually be a much better dentist, because you know what the protocol is, right? So again, the special scissors we use to cut the polyethylene, high molecular weight polyethylene fibers. You etch the lingual surface, etch, bond, Scotch bond. You put the fibers, you tuck it in, you make sure you have a nice convexity to the facial aspect. You stabilize that with your composite. You make a groove. You take your 330 diamond burr, you make a groove on the lingual aspect of the extracted tooth, and you place the tooth against the fiber, because now you have a nice mechanical interlocking, right? You place that fiber, you place the tooth against the fiber, you place some flowable composite against the side of the tooth, you stabilize the tooth, and you build more composite. You have a much better template with a rigid structure, right? After I did my little bit of composite, I etch all over again, bond. At least the outcome is much more easier. And now again, all these are temporary solutions, right? Because the ultimate goal is for a patient to get an implant. But sometimes you might say, I like this, I'm gonna keep this as is. And again, I tell them 3 years at the most maximum. And if it works, it works. But so far, again, all these patients are really happy with the outcome, right? If you look at the data, right? So back in 2007, when I started doing these procedures, I didn't have much of a template for me to adhere to, right? I had all these papers in 2000 by Valitu. The uh, the patients that they followed was 50. That's it. And then, but however, there was a systematic evidence-based review done in 2017, and they followed 463 patients with 524 with the 526 fiber reinforced composite bridges, and the success rate was 95% for 5 years. Hey, anything above 90% is pretty good, right? Right. So I would probably tell the patients 2 years. I'll give you a guarantee this should work for 2 years, right? But then again, you tell the patient, right? You save money, you come back, and then you can always like get the fiber removed and go for an implant. But again, so far, again, there's a lot of things that goes on with the longevity. Single tooth replacement is the best way to go about with these fiber reinforced composite. Again, if the fibers do get debonded, it's very easy for you to repair it. All you have to do is just roughen the surface, etch, bond, everything, and put the fibers back in. Um, Again, all these are cases that I've done in the past. This is all the students' clinic. This has worked in the hands of a D3. I still remember the student, third year dental student, right? And actually, he was ecstatic. He was like, "Oh my God, this is awesome!" So, and I'm sure you'll probably have an opportunity like these plenty in the coming years. But again, just to highlight the fact that, as long as you know your material, the clinical protocol for materials, it always works. I've had bad success, or I had greatest failures in the lower teeth. Can anyone tell me which tooth have I done the composite? Have I built the composite on here? Didn't ready. Perfect. All right. Maybe you know what this case, no, but yeah. So this is one of the colleagues. A colleague spouse came to me, and of course 25 is what we did. We built the tooth up with composite, and we, of course, I went out of the way. I did all the grooves, all the stain and everything, and then she came back, and I need to actually replicate the same abstraction. So I had to go in, I had to create an abstraction, create a notch. I did everything right, but then Again, patient compliance is always a hard thing for lower fiber reinforced composite because of because of sometimes the fibers can irritate the tongue, and the patient likes playing around with that fiber. And most of the time, because of all the plaque buildup, the chances of fracturing is always high. Right? Again, more patient complaints from the bottom fiber reinforced composite. But again, all these are easy to fix, easy to repair. Right? So summary, again, it's a minimally invasive technique. It's totally reversible. All you have to do is take the fiber out, you polish it off, and then the tooth goes back to normalcy. Right? Lower cost to patients for sure. Great alternative to patients. You have to get the patients back for periodic recalls and make sure there's no chips or fractures, because anytime the fiber gets exposed to the oral environment, that's a failure, right? So you have to probably make sure you go back and you do all the repairs. And we use a lot of codes for that. We have a provisional Ponte code, we have unspecified fixed prosto procedure code, and sometimes they use four or more surfaces composite if the patient really needs help.